Okay. Okay,
Him and
good.
I were just
Okay.
talking shop.
Perfect. Um, were you loving my Harry Potter reference? Because I feel like, okay.
Absolutely, that's exactly what it was about. I love Harry Potter. My kids are super into it right now. I was just telling them when your kids get old enough, the book reading at night becomes much more interesting. And so I was sharing how excited I am that I'm at that stage of life.
So on my notes section, sorry, this is a bit informal, but on my notes section, I put Hogwarts would be more fun. So that's about where we are. Um, so all of these patients reaching out and saying, what are we supposed to do? And again, we don't have a ton of guidance. These medicines are designed and tested to be used for chronic disease management. So it's kind of like a patient saying, well, what do I do when I come off my losartan? Well, I don't know. I guess your blood pressure is going to go up. We can add something else. But there aren't a lot of studies on going off of losartan because it's managing a chronic disease. So we're in a little bit of the uh, same boat there, though we are in that boat whether we like it or not. So these are the options kind of as I see them. So option one for patients is to just transfer, and we're going to go through all of these in a little bit more detail. So option one is just to be continue management without change. Transfer to cash pay, we'll talk through that. That is an evidence base that's continuing chronic disease management with no dose adjustment. So we'll talk about opportunities there. Option two also has some evidence to back it, and that is transitioning to a lower cost medication with the goal of weight maintenance. Now, we do again have some data. There's a couple studies that we'll go through that have some options there, just so we know kind of again, what we can help to counsel our patients. And then option three is really just to get creative. We'll kind of, again, work through all of these individually. So this is the easiest. Transfer to cash pay. This doesn't change the person's health journey. This is just going to be to continue what they're on and where they're going. So two different companies make these medications. Eli Lilly makes the Zepbound Quick Pen and Fundio, which is the orglipron. I always put the L in the wrong spot. Notably, the vials are actually kind of phasing out, and so the Quick Pen is what they're phasing in. You can see cost there. This is not insignificant. So if we have someone taking 15 of Zepbound and they would like to continue to take weekly injections, that's $449 a month. Now, the cost is significant, but it's not complicated. So on our end, we simply send that prescription, if it's an Eli Lilly product, to Lilly Direct or any Walmart pharmacy and let them know that they are cash paying and they go pay for it and pick it up. It's not a complicated solution there. For any Novo Nordisk product, which is going to be Wegovy or oral Wegovy, very same thing. We can either send that to NovoCare, which is built into the system, or many pharmacies will actually match those NovoCare prices with a GoodRx card if the patient is one that really, really wants to pick it up in person. So again, we've got an in-person option and a mail option, no matter what the person wants to do. But you can see where that would transition as far as cost. So cost, depending on dosing, is going to be in between $150 and $449 a month to continue the exact regimen that a person is on. I'll just keep going, but please feel free. Anyone can just throw out um, questions as we go here. So option two, this is a bit emerging. So there's been two studies, as I mentioned, looking to for a transition to cash pay, but looking at maybe a lower cost option. So we'll go through these individually. One is the Attain Maintain, that's looking at transition to orals, and then the Surmount Maintain is just a reduction in dose. So this is the Attain Maintain. This is looking at, so Surmount 5 was a head-to-head trial with tirzepatide and semaglutide. And so they took patients at the end of the Surmount 5 who had completed that trial and then did a 2-week screen and put them into this Attain Maintain. One of those groups, or there were two groups with each of them, but one was a placebo group, and then one was transitioned to the orforglipron or the Fundio medication. This was a less than 14-day screening period, which is important because you didn't have to restart any sort of GLP-1 titration. But those individuals were started on a 9 milligram dose, then a 14 and a half, which actually we use a 15 and a half, and then up to the highest dose of this medication. And then they looked in, and then they did that for another year, and they looked and saw what happened to those individuals. So here is kind of a screenshot of just what the whole study sort of looked like. So here over in yellow and brown, this is just Surmount 5. So this is patients were on semaglutide and tirzepatide and what happened. And we know these are the numbers we tell patients all the time. So on tirzepatide at a treatment dose, we expect 20 to 22% total body weight loss. And on semaglutide at a treatment dose, we expect kind of in that 15 and a half to 17 and a half range. So this is what we already know. Here's the 14-day screening period. And then this is only people on treatment. So this is not placebo. So those individuals had a very, very modest amount of weight gain during this screening period and then started again, 9, and then titrated up. Again, the numbers look a little bit different just because of where it is in marketing, but started on therapy and titrated up to highest doses. So so there was some weight gain, absolutely, but they had a really nice amount of weight maintenance as well, which we'll kind of look through because there's a couple different ways to look at that. Get to my next. So this is looking at, I had it in my notes too, and I don't see my notes now, but so this is looking at how much weight was maintained for individuals who were after a year, they were on Surmount 5, they were either on placebo. So now we've got the placebo coming in versus those that were started on the orforglipron, the Fundio, and then titrated up. So for those, this is the tirzepatide cohort. So for those on treatment out of the tirzepatide cohort, they maintained about 70% of their weight reduction. For the placebo group, they maintained a little less than half of their weight reduction. So this group didn't gain all of the weight reduction back, or I'm sorry, all of the weight that had been lost back. And then the tirzepatide group kept about 3/4 of the weight reduction off. In the semaglutide group, this is the exact same thing. So about 40% or so maintained weight reduction and about 80%. So actually switching from the semaglutide to the Fundio, probably because they didn't lose as much at the start. So obviously those starting numbers are a little different, but some pretty significant weight maintenance on this. And just as a little reminder, I'm going to go back fast, which is hard to do. But so this would be going from 449 over to potentially like a $299. So that's what we're looking at from a cash pay perspective. So it would save or from 349 to 299. So this is a de-escalation to save money, essentially, with the idea that they're going to gain a little bit of weight back. But if we can save them between $150 and $50 a month, and that fits better for their budget, that is an option. So there is always kind of in weight management data, there's a little bit of kind of responder, non-responder too, that's important to look at. So this is the amount of patients who maintained at least 80% of the reduction in body weight that they had in Surmount 5. So with the injectable medication. So about half of the people maintained at least 80% of weight reduction. So on average, it was about 3/4. But again, there's kind of a responder, non-responder phenomenon. Very same with the semaglutide. So 58% of people maintained at least 80% of their total body weight reduction. So there were certainly some responders to this medication, even though on average it was about 79%. And then very few responders, but not none, that about 8.8% of people, even in the placebo group, did maintained 80% of the weight reduction. And then again, in the tirzepatide group of about 15.2%.
Hey, Sarah, sorry. Do you know what's the responder versus non-responder? Like, why do some people respond better than others?
So
It's out there.
we don't necessarily know. And it wasn't looked at in this trial. So, like doing subset analysis, but what's different about these individuals, I'm sure it will, but it has not yet been published. Now, I have a slide on it later thinking about so, how can we tell who are the responders versus non responders? And so, again, we're going to talk about that in a minute. Can I punt that? Do you mind?
No, that's fine. I think John has a question too.
Okay.
I was going to ask for the tirzepatide cohorts, like the placebo group, they seem percentage wise to lose less. Do you think it's just because they had so much more robust weight loss, and if we extended the trial past 52 weeks, that you would kind of see those numbers kind of come close to the semaglutide numbers?
Yeah, I expect that. I think I heard your question. I apologize that I didn't hear every bit of it. But I think that the semaglutide numbers are more favorable because the weight reduction was less at the outset. Is that what you were saying? Yeah. So I don't think there's anything remarkably different about that transition. I don't think it's a chemical change that is like more favorable. I think it's just because of the overall weight reduction numbers. Okay, so the next trial, there we go, is so this is the Surmount Maintain. This is looking at continued injection therapy just with de-escalation of dosing, which again, in this particular context, is going to be cost saving for people. So this again was people who were escalated to treatment, and then at week 60, they were randomized to either placebo, 5 milligram, or essentially no change to their highest tolerated dose of the tirzepatide. And you could see what happened here. Very typical. So over 60 weeks, 4 individuals on these are, I mean, this is what you see over and over and over. 4 individuals who were on their max tolerated dose, they lost a little over 20% of their total body weight. Then they were randomized. And so this was continued therapy without change. So then those individuals kind of went into plateau just as you'd expect. Then this is the group here, kind of in this peach color, that was reduced to a 5 milligram dose. So again, cost savings here is going to go, I'll go back to that slide, but you'd be looking at 449 to 349. So I think this is $100 difference for people. So absolutely, when that dose adjustment is made, you do see a weight increase, though you see a nice plateau and still at a 17% total body weight reduction, which of course we know is way more than we're generally looking for from a clinical perspective. So this can still be very important. The placebo group, ultimately, so all of these trials have a rescue. And so if we were extrapolating with the placebo, they would go back to about 4.8, which is similar to what the other study showed for the placebo tirzepatide group. Because they have the rescue, they put him back on therapy and then they were able to plateau there. So this is looked at in a little bit of a different way. So this is the change in body weight from the time of randomization to week 112. So this is just what happened during the time of randomization. So ultimately, they're very, very similar, but people without a change lost a little bit more weight. People that changed to the 5 gained about 6.5% of their total body weight back. And then people that were on the placebo would be estimated to be at 14.9%. That, of course, there was a rescue opportunity there. But so they gained about, about half of the weight kind of that they would have with a placebo with no rescue. And that's just in this study. So, same thing. So this is looking at kind of responders and non-responders. So, this is okay. Well, we know on average people gained 6% back, but how many were really maintaining weight even on the 5? And we know about 44 or 42, kind of in that range, percent of people maintained at least 80% of their weight reduction, which again, and then about 60% didn't. So the numbers that we were looking at before are average, but who's a responder and who's a not responder? So about 80, for about 40% maintained 80% of their total body weight reduction. So again, there's a responder, non-responder. So we don't know who they were in this study. They haven't been looked at. It hasn't, their sub-analysis have not been done. But we know in general, again, time and time again, that the best responders to GLP-1 medications when it comes to weight reduction are premenopausal women who are co-treated with metformin therapy. So I think that we can knowing that is somewhat powerful because when we're looking at these opportunities for people, I would maybe recommend a premenopausal female that was co-treated with metformin or that we could start metformin. Go ahead and try a de-escalation. If that works for your budget, you're a person who may actually be a really nice responder and you can maintain 80% of your um, total body weight reduction by being on 9 of the orforglipron and then metformin. So I think these are people who I would be a little bit more aggressive. While everybody gets to make a choice of what's right for their finances, these are people that I would be a little bit more aggressive to say it's probably worth a shot because we know that you are more likely to be a responder than a non-responder. So this is another thing I'm a little off.
Unless, I'm sorry to interrupt you there, but there was a question relevant to that last slide. I just want to make sure we address here. So does it matter if they are pre-diabetic for the metformin to be beneficial?
No, in general, people with prediabetes do not respond quite as robustly from a weight management standpoint. That is consistent with, we know people with diabetes. So Ozempic trials, or I should say Manjaro trials, don't show a 22.5% total body weight reduction. We know that people with metabolic disease tend to respond a little bit less robustly. So it doesn't matter for this kind of if we're trying to guess on responder or non-responders, but we know in general those with metabolic disease have a little bit of a less robust response. So that is a nice segue though into okay, but we're all of this is based on weight reduction, which I think is an appropriate spotlight for us because that is kind of the spotlight that our patients have right now. But also, I think we want to know okay, but if we back off some stuff, are we still going to get those really nice metabolic benefits that we want to? So I'm pulling back from the attain maintain. This is the de-escalation to orals. But people had generally, the tirzepatide and the semaglutide cohort, continued improvement in hemoglobin A1C. Now, the patients were pretty good at baseline. It's not like they were folks that had uncontrolled diabetes. Obviously, they wouldn't be in this trial if it was. But so they had 5.6 and then went down to 5.2 in both cohorts and maintained that even though they had, again, that little bit of weight reduction, or I'm sorry, weight increase when they were randomized. So they also had continued improvement in lipid profile. So again, these are not patients who had incredibly uncontrolled disease at baseline, though especially for semaglutide, which is kind of interesting because we know there's been more cardiovascular benefits tied to the semaglutide. We had even at the lower dose, we were able to see continued improvement there. And then they didn't, or and then looking at continued improvement in waist circumference. So just kind of that metabolic syndrome. They had some stuff on systolic blood pressure too, but I didn't post that because it was good to start and it was good to end. So it didn't really have any sort of clinical relevance. But waist circumference decreased. You can see kind of by the amount of centimeter change there. And then you can see there was a small increase, but actually less significant than that of weight increase. So they have continued metabolic benefits even on those lower doses.
Sarah, sorry, just one follow-up question, kind of going back to the metformin question. So just to drill down a little bit. So it's okay to use the metformin regardless of their A1C from a weight
Yes,
standpoint is what you're recommending.
yes, absolutely.
Okay, thank you.
So option three has no literature to guide us. This is where it becomes, I don't know what happens when you stop losartan. I guess your blood pressure goes up. And what would happen if I took losartan every other day? I don't know. It would probably go up a little bit. So again, this becomes a little bit more outside of what we have from a literature perspective and a little bit more like this is the kind of things that we've tried and this is kind of where we are. So I certainly know this has been talked about quite a lot and people have experimented with it, but increased interval of GLP-1 dosing. So in general, I think moving to 10 days it can be pretty effective, not with weight reduction, but if someone is comfortable with weight maintenance, that gets them to 40 days in between each purchase. That's not a huge change in their overall cost, but if that's really important for that patient, I think you can. I think to go to every 2 weeks becomes less consistent. I do not see as helpful. I do see weight increase, I would say, with a Q14 day dosing. Again, they're probably a responder, non-responder because we're just functionally decreasing the dose there. So it's not wrong to try it. But I do think at that 14 days, as a general rule, I start to see some weight increase for people. Now, something that you could certainly consider doing, and I know Hannah Peterson is really kind of thinking through, is using kind of some PRN hunger support. So if people can go to Q14 day dosing because that works for them, maybe using 15 milligrams of phentermine on those off weeks to help control hunger in the days prior to your next dose. Well, again, we're making our own way. If you want to do that, if the patient is saying, um, hunger is a huge barrier, but it's only a barrier for these few days, well, then offer some support for just those few days. Phentermine can absolutely be used. PRN, again, I know I've talked about this before, but I generally start at a 15 milligram dose and to use it in that way. So we have great data with topiramate phentermine that they're not going to, our patients are not going to have coverage, or our health system employees are not going to have coverage for like a Contrave or Qsymia. So we can't just de-escalate to oral obesity management medications that are FDA approved. But you can certainly use topiramate and phentermine as a combination therapy, and that is extremely inexpensive. Now, weight reduction with topiramate and phentermine in general is going to be in that 12% total body weight reduction. So that is going to be less than, I mean, if you're kind of extrapolating numbers, that's going to be less than most people get with a GLP-1. So if they were on that regimen and had weight maintenance, I actually think that would be a win. I would say that's okay because you were at 17% total body weight reduction. We transitioned your regimen. You haven't lost any additional weight. However, that's okay because we knew that weight maintenance was part of the goal here. Utilizing metformin, again, especially for those premenopausal women who we know are kind of super responders when it comes to that medication, as long as they can tolerate it. So we use a decent amount of the SGLT2s. They're really helpful. Obviously, we don't have to talk about the benefits of these medications. I think we're all pretty on board with that. But they are very expensive if you don't have coverage. So Mark Cuban has, for $60 a month, you can get SGLT2s through Cost Plus. And so we add that a decent amount, especially for those individuals who you think a little bit of metabolic support would be helpful. So they're not really struggling with cravings. They're not really struggling with hunger. We just know their body is really, really holding on to more sugar than it should. Utilizing that SGLT2, again, that's $60 a month. So we're still talking about bigger numbers for patients, but that is certainly an option. I'd probably be more aggressive to transition people off obesogenic medications. We have really been spoiled in a way because these GLP-1 medications are so helpful that if somebody comes on, fluoxetine and they're like, yeah, I've gained 15 pounds, but this is a great medicine for me. I love fluoxetine. Um, that we can be like, okay, well, that's fine. We'll, just kind of manage drug associated weight gain, given that this has been a perfect fit for you in other ways. But I would be a little bit more aggressive with that and say, okay, well, maybe we can get you over to something that's a little bit more dopaminergic in order to take away that obesogenic side effect.
Sarah, I
So,
think you got a couple, if
yeah.
it's okay, time to pause. We have a couple things in the chat here. John just kind of told me about dapagliflozin is also now on Mark Cuban for 11.21.
Yeah.
Oh, great.
For 90 days, it's like $15 shipped.
50?
15.
15. Wonderful.
Yeah.
So that world is starting to open up to us with Mark Cuban Pharmacy, or the Cost Plus Pharmacy, which is helpful. I'm going to read a couple questions to you, Sarah, that kind of relate to what we're talking about on the slide. So the first one is a really interesting one. I'm just going to read it verbatim. So I've heard of some data that basal metabolic rate decreases with pre-GLP-1, period of GLP-1, then post-GLP-1, i.e. someone who has to stop will have a lower basal metabolic rate than they had before they started. And wondering if that data has been replicated or if you've seen that, or is that fact or fiction, basically?
Yeah. So absolutely fact. Now, I've never seen this data for GLP-1s, to be honest, but this is a well known phenomenon with weight reduction in general. It's actually, there's a name for it. It's called adaptive thermogenesis, but driven by a decrease in skeletal muscle mass, which is okay. You don't need as much skeletal muscle mass when you're moving a smaller body. So we certainly, this is a little bit of an aside, but we want to be really, really careful of individuals who present to us with sarcopenic obesity. So they are saying, or their healthcare team is saying to us in primary care or weight management, we really need to help this person lose weight. Great, but they can't stand from a chair. So that is a really tough time where we need to be aggressive with PT and that kind of thing. But in general, for people who are perfectly functional and living their life and moving all around and exercising, they're still going to lose skeletal muscle as we see weight reduction for that individual. And as a function of that, and as a function of the caloric reduction, which everybody is in a catabolic state when you're losing weight, you do see an adaptation of basal metabolic rate. And it does not improve. It does not get better, even if we see a weight increase, because generally a weight increase in the setting of like weight cycling is not actually development of skeletal muscle. That is more adipose tissue that is gained. And so, again, I've never seen a study looking at that with GLP-1 specifically, only because it is so well documented, kind of in an obesity management setting. So, yeah, that's 100% true.
Okay, then a couple questions around phentermine. So one is, I just want to make sure I heard you right. So phentermine in the studies shows a 12% body weight loss. Is that what's quoted? And is that a
So
15 or is that at the 37 dose, or what dose is that gets you that?
So if we extrapolate data from Qsimia, so utilizing topiramate and phentermine together. So that is, I generally use like 50 BID of topiramate. The topiramate that's in Qsimia is a long acting. Which is more expensive. And if we're using that, then we're trying to get away from expensive things. And then the Qsimia goes up to 15 milligrams of phentermine. So it's often kind of how I try to mimic that. And again, if we're extrapolating from the Qsymia data, we'd expect about a 12% total body weight reduction.
Okay. And so this, although it sounds like there hasn't been an explicit study of transitioning
Correct.
off of a GLP-1 to phentermine, but we assume that there'd be probably close to maintenance would be our expectation.
So
Maybe
we
steady.
will have to see. It seems like they would continue to have some support. We know that this regimen is not as powerful from a weight reduction standpoint, but we know that it's going to be super cheap. And we're just going to kind of have to see a little bit how it goes.
And just for something that you've helped me with, which is getting more comfortable with a longer course of phentermine. Right. I don't know if you want to speak to the safety data on that or.
Yeah. So our longest study on phentermine, which phentermine is super cheap, it was FDA approved in like the late 70s, and no one is doing any studies on phentermine anymore, just because nobody's making any money off of it. This is probably 10 years ago. I haven't looked at that study in a while. But there was a 2-year study that was looked at just for safety with phentermine. Um, and it was non-inferior from a cardiovascular standpoint, essentially. There was no increase in blood pressure. There was no increase in cardiac events. That was up to a 37 and a half total daily dose. So um, that can be administered as a single dose in the morning. It can be administered after breakfast and after lunch in like 15 milligram dosages. But if the total daily dose is under 37 and a half, again, we do have some data that there's no increased cardiovascular events.
Okay, thanks, Sarah. A couple more here. And sorry, I understand it. Let me know if you can't hear us well enough here. Do you have an opinion on phentermine 15 versus low dose 8 milligrams TID phentermine?
I do not. I think uh yeah, if a patient likes to do TID dosing, I mean, I would generally avoid phentermine. If phentermine is best managed and is recommended to be taken on a full stomach, so TID dosing, you'd be taking something after dinner that feels like it would interrupt their sleep. But if it didn't, and that person had like an incredible amount of challenge with like evening cravings and then went to bed at midnight and slept like a baby, then go for it.
Okay, good.
And if we did this intermittent dosing with phentermine, like usually when I would do phentermine, it's 15 for a month, see how they tolerate it up to the 37 and a half. If someone tolerates the 37 and a half and we're doing this intermittent dosing, is it cool for them just to go back to that 37 and a half and take it instead of, I mean, or else you can't titrate that every single time.
Yeah, I generally pretty much always start back at a lower dose. Because with stimulant therapy, you're gonna have, I mean, it's not so different in the way of like side effects with GLP-1. So no, I wouldn't necessarily go up to 37 and a half. I would always start them on a lower dose.
And then here's a question around switching from weekly injectable semaglutide to an oral semaglutide, but taking it every other day. And so kind of, having some experience, having a patient where kind of did that and did some weight maintenance. But do you know of any studies or data, or even in your own personal experience of using kind of the every other day semaglutide or some sort of intermittent dosing like we do, like people, like, because you had kind of mentioned extending the interval for the injectable ones, I guess is.
Yeah, I don't have any data with that. And I've not actually tried it as much from a clinical standpoint. The half-life of the pill is 7 days. So from a pharmacotherapy standpoint, that should be fine. It's a very long acting. We looked into it when we were trying to figure out how long people were going to need to hold medication prior to testing. And it's no different actually than the injection therapy. So it has a very long half-life. There's no reason. It's kind of like a daily microdose, really. And so there's no reason you couldn't do that. I feel like that's a lot to try to remember whether you took it the day before or not. You have to have a really good like pill bottle um system of going up and down or something like that. But there's no reason it would be unsafe to try that.
I think one of the things that comes up whenever we're spacing out these medications that isn't kind of the way that they're supposed to be taken is whenever we're using these programs that are allowing us to get these kind of discounted prices a lot of times, especially like Lilly, I've had patients be like, if I don't get it within 45 days, it's a problem. So like the Q14 day thing just doesn't even make sense to me because like, I don't know if they'll still give it to them, if they get like a point system. I guess like, how do you navigate that if they're not refilling it on time every month?
So I would recommend if somebody's taking it every 14 days to just go ahead and get a few refills and put them in your fridge. That's going to be easier. They'll still be able to get it, but there's a financial penalty for going above 45 days with Lilly. I can't remember what it is, but it's not insignificant. Like, I don't know, maybe somebody else knows. But I usually say go ahead and get, 3 refills, put them in your fridge, and then there you've got 6 months worth of medicine.
Yeah, sorry. I didn't realize there was that penalty for waiting, and that is just obscene. That's like holding them hostage. You get somebody on a medicine they need every. No, I'm sorry. I won't go totally down that rabbit hole. Okay, we got one more question in the chat, Sarah, and then I'll let you get back to your presentation here. But so it seems like in these patients that want to lose weight, we can really push the GLP-1 dosing, and even though A1C is dropping in the 4 to 5 range, they aren't having hypoglycemia. Any concerns with pushing the dose up? I think probably trying to get more weight loss, but and someone with a A1C that's down in the 4s. Do you have any concerns with that?
No, unless they're symptomatically hypoglycemic, which it would be a huge shock to me. And honestly, if they were symptomatically hypoglycemic, I would really spotlight what they're doing from a nutrition standpoint because these medications are generally not going to drop people to a symptomatic level.
Okay, we're all caught up, so we'll let you get back to it.
Okay. So behavioral support, big question. We know there are things that make these medications work better. We know there are amazing things that can help us live longer. Oh, I guess I didn't do as well with that. So I'll talk about it right now. So 150 minutes a week of moderate activity with 2 sessions of resistance training is, of course, what's recommended by the American Heart Association. That is also recommended by folks who are really looking at exercise and weight management. However, actually, Joe Donnelly, who is our kind of research partner, has a lot of data that for weight maintenance, pushing activity up to 300 minutes a week with 2 sessions of resistance training can be very helpful. So, in the right patient who is super motivated to see what they can do from a behavioral perspective, moving into that 300-minute a week category, which is 5 1-hour sessions of exercise. With then again, 2 sessions of resistance training could be, there's no exact literature to guide it in this scenario, but could be helpful for weight maintenance. Also, oh, I guess I did do that right. Also, when it comes to nutrition, so we have all been counseling patients on nutrition with GLP-1s, saying you need to eat regularly. We want to make sure that your first bites are your most valuable bites of food. We don't really want you to eat like a whole bunch of soup because you're going to take 4 bites of soup and be totally full, and you're not going to be able to get what you need from a nutrition standpoint. And now, from a behavioral standpoint, if somebody's coming off their GLP-1, we're actually going to switch that back completely and go back to kind of a stoplight eating plan. So this is based on how much water's in your food. This is based on the volume and really looking at nutritional density. So we want to go back to tons and tons of fruits and vegetables, doing things that are very high water content because they fill people up and give you a lot of nutrition, but with a very low caloric intake. So again, this is kind of the opposite of the nutrition plan that we use and really we want people to kind of live with yellow foods when they're on a GLP-1. Make sure you get enough fiber, but you're going to live with yellow foods. We want them to go back to green foods and really, really kind of have a high volume system. So I put compounding medications on here only because I have been surprised at the number of patients who have come and been like, well, my neighbor's getting this for $49 a month or whatever. So my stance on compounding medications have not changed. I don't actually think they're that much cheaper, though I'm certainly not an expert in that sort of silo of management. But many of them you have to like buy a membership. And so you're paying like 150 bucks a month to be a member, and then your drug is maybe cheaper, but at the end of the day, it's really not that much cheaper. And then there's no FDA regulation. You don't really know what you're getting. We work at an academic center, and I think it's probably inappropriate, certainly, and again, maybe for each person to make their own um, decision on this, but it feels very inappropriate to me at a university center to use something that we don't know what the medication is and it's not regulated by the FDA. And there's been strong statements from our kind of overseeing bodies on avoiding these as well. So that is, here we're at 251. That's what I have for GLP-1s coming off, what the data is, what the data isn't. Any other questions on that?
Sorry, couldn't find the mute button there. Okay, there is one around using Wellbutrin as a single agent for weight loss at all, not in the combo form. And maybe actually that's while you're at it, if you don't mind talking about use of naltrexone.
So I don't find bupropion naltrexone to be incredibly helpful and impactful for people on a weight reduction journey. We know if we're extrapolating data with Contrave, which of course, when it's used in combination, that's what drug it is. There's about an 8% total body weight reduction with that medication. So it's clinically meaningful, not as meaningful, I think, from a patient standpoint. I do think, so I don't know that I would go to that unless you were really out of options. I do think sometimes getting off of medications which have induced weight gain and transitioning to bupropion can be very helpful, but adding that as a weight reduction agent, I think, is generally less helpful. Okay, keep going.
Yep.
Okay. So 7 minutes on kind of Medicare Bridge updates. This has the biggest takeaway, I think, and I'm certain that we have all managed medications through the GLP-1 bridge, is that this is an additional, not alternative opportunity. So what happened on July 1st, Medicare added GLP-1 really for the management to their formulary, essentially. This was 4 medications, the Zepbound Quick Pen, again, Wegovy, the Foundayo, and then the oral Wegovy. So eligibility is BMI greater than 35, a BMI greater than 30, and heart failure, hypertension, CKD, or BMI greater than 27 and prediabetes, or some cardiovascular disease, a major cardiovascular event, and not eligible through Part D, which has been the biggest challenge, I think. So many patients were hopeful that they could get GLP-1s through the bridge and not go through their Part D because it would change their coverage, but that has not been something that has been an opportunity. So again, it's an additional opportunity, not an alternative opportunity for patients. So I mentioned this briefly the other day, this Medicare prescription payment plan. So this is so for Medicare, and you guys have seen this, I'm certain, but you pay 100% until you hit some sort of point. And that I think it's at $615. So every piece of pharmaceutical cost is on you if you're a Medicare participant until you hit a certain amount. Then you get some co-insurance for a bit. That then gets you to your cap of $2,100 and you have no additional out-of-pocket costs, which is fine in theory, except if you go to the pharmacy and they said, okay, that'll be $615 and you don't have $615. And then it can be even more than that because then the co-insurance kicks in here too. So you might have 200 of this. So So this is a hurdle that some patients just cannot manage to get over, even if that means on month 3 of the year, they're not going to have any pharmaceutical costs. So that is what the Medicare prescription payment plan is designed for. So this is something that the patient has to sign up. This is actually in a link, but you guys can find it too. And the costs do remain front loaded. So it's not like, they don't just take $2,100 and divide it by 12, but because there's an algorithm, and I certainly don't know that algorithm, but it does make it so that costs are going to be a little bit more expected and spread out throughout the year. So I think it ends up being the first couple months for all of your medications are like in the $300 to $400 range, and then that moves to the middle of the year. They're in that, $200 to $300 range, and at the end, maybe they're in the $100 range. So again, it remains front loaded, but it definitely protects a patient from having to jump this whole hurdle at the same time. So for people who are not doing Medicare Bridge and are very interested in being on any medication, this is not unique to GLP-1s, but any medication which is going to have a really high front loaded cost, I encourage them to look at that prescription payment plan. So again, just an overview, the bridge in Part D. You guys can read that, but I think we already kind of went through it.
And we have a question in the chat that's basically saying, like, what is the full criteria for Medicare Part D to cover Zepbound in a patient with moderate to severe OSA? I recently had a patient that has an AHI of 50, BMI 28. It was denied. I've run into this where my patients are like, it's $500 and technically it is covered, but it's like, it's still a $500 medication. I don't know.
Yeah, so then you look at the Medicare prescription payment plan because it shouldn't be denied. It's covered. It's just really expensive.
I
And
can
that's
take this
because,
one. Maybe you were just about to answer it. So the bridge program is only for patients who the medication is not approved for. So because you have OSA or NASH or whatever it may be, you end up having to pay the higher copay than for weight loss, which is silly. And we've definitely seen patients be very irritated about that.
Yeah, and I think
so
the question is actually just straight up about the Medicare Part D coverage, not even including the bridge.
yeah, I don't, that seems a little strange. Quite honestly, if they're denied for Medicare Part D, I would quick submit them to the bridge with that letter because they should not be on the bridge, but the patient may be happier if they can get it for $50 a month. So I don't know. It sounds like it was a mistake, honestly. I would probably just ask or tell that provider to talk to their nurse and see if you can look at that documentation because it sounds like something just didn't get through right.
Okay.
That is what I have. Please email. Again, there are some things that we know. There are a lot of things that we don't. We know that we can transition to orals for a lower cost. We know that there's going to be responders and non-responders to that. We know we can transition to a lower dose. The study that Surmount Maintain was specifically with that tirzepatide at 5 milligrams, which is going to save people about $100 a month. And then after that, we don't know much. After that, we can go to 10-day dosing pretty comfortably. 14-day gets a little iffy as far as we tend to clinically see weight gain at that point. Transitioning to other medications would kind of be our options there. A greater than 300 minutes a week probably has some benefit from a cardiovascular or from a weight maintenance standpoint. And then again, transitioning our nutrition recommendations away from those higher density, high nutrition food to actually lower density, high nutrition food so that people get full faster. And so we can kind of utilize that finite space in a way that's more advantageous.
Dr. Comfort and I were talking about how amazing it was that you put this together in like a week. Like we asked you 7 days ago and you're just like, and here it is. It's just amazing. So, Dr. Stolte, we appreciate it. Thank you so much for coming on short notice. This is always enlightening. We look forward to having you next time.
For sure. Hey, one thing I want to say too. So a referral to weight management, we are obviously happy to see anybody who you would like us to see or they want us to see. We do have actually a hard stop in our referrals. So we won't see anybody with a BMI less than 30. This is obviously a little bit of a unique setting because it may be somebody who has lost a significant amount of weight, but now no longer has access to those types of tools. Just message me. I don't think there's a great way to get around it because the PSRs are the people who hard stop it. So just message me and say, I know that BMI is less than 30. Just like CC me on the chart or something like that. We're happy to see anybody, but there will be a hard stop in the system if we don't kind of do that workaround.
Yeah. All right. Good information. Thank you, everyone.
Thanks.
Bye.